Okay, let's get started, everyone. Welcome to another online causal inference seminar. We are very happy today to have Erica Moodie from McGill University, who will talk about flexible modeling of adaptive treatment strategies for censored outcomes. We have two excellent discussants today, Cheng from University of Pittsburgh and Peter Thall from MD Anderson. Before I give the floor over to Ying, I want to mention that our online causal inference seminar family is growing, and we have four more excellent researchers joining our team. Naoki Agami, Laura Forestiere, Sara Magliacane, and Razi Nabi are also going to be part of our moderation team. So now I'm going to give the floor over to Ying for talking about how Q&A will be dealt with.
Thank you, Georgia. So as usual, we'll use the Q&A button at the bottom of the Zoom window to track the questions. So as long as you have them, please submit it using the Q&A part for us to better track it. And we encourage you to submit a question as soon as you have them. And when it is necessary, Georgia will I will pose the question to to Erica. With that, please feel free to take over, Erica.
Thank you. Here we go. Thank you so much for inviting me to speak today. It's really a pleasure to be here, and I will just rearrange various bits of my Zoom screen. There we go. So what I will be talking about today is some work that was started by a former master's student of mine, Ferdous Hossain. And following the completion of his degree, we sort of expanded and, if I may say, finalized and polished the work a little more with my collaborator, Brent Logan at Wisconsin, and his PhD student, Xiao Li. And so what I'll be talking about is a flexible or non-parametric approach to modeling adaptive treatment strategies when we have time to event data. So what I'll be talking about, or how I will sort of present the work today, is I'll talk a little bit about the idea of precision medicine in the statistical literature and how this is framed in a sort of causal setting, or what comes up that's causal about it. I'll introduce the idea of Q-learning, which is a regression-based method of learning about adaptive treatment strategies, and then talk about how we can extend this to censored outcome or survival settings, and how we implemented this with an accelerated failure time model using Bayesian additive regression trees and a more Bayesian implementation of this analysis. And finally, I'll finish off with a case study looking at how we can prevent, or if needed, treat graft versus host disease in a population of transplant patients. So I've been, I don't know if I've reached my sort of middle age as a statistician, but I've reached the age where I keep getting asked to look back at, X anniversary of important papers by important people. And Sir Austin Bradford Hill has had a few sort of paper anniversaries lately. And in reading some of his work, I came across this quote, which I absolutely love. "The medical statistician recognizes and is familiar with the pros and cons of that difficult question. Should a fixed dose be given, or should it be allowed to vary with the apparent needs of each patient as judged by the clinician?" And I thought this was really interesting because we often think of Bradford Hill as one of the sort of forefathers of the ideas of modern causal inference, not, what can I say, the counterfactual framework that we work in, but the sort of non-criteria that he proposed for establishing causation, and much of the work that he did in understanding how to think about, healthy worker effects and exposures in the workplace. He's done a lot of really interesting work, and yet much of the causal inference literature is focused more on marginal effects. The average treatment effect, for example, or even the average treatment effect among the treated, it's a subgroup analysis, but it's really marginalizing over covariates rather than explicitly trying to tease out treatment effect heterogeneity. And so I thought this was quite interesting because he's really asking, well, maybe we shouldn't always be thinking about that policy question of what do we give everyone if we can only assign something to everyone, but rather, if I can treat the individual patient, how should I do this? So when I talk about precision medicine, what I'm really talking about is trying to tailor a medical intervention or some other sort of intervention. It could be a behavioral intervention to the individual characteristics of each patient. But if I'm honest, I'm not really talking about precision medicine in the most personal sense. I'm trying to classify individuals into subpopulations based on how they respond to specific treatments. I'll be doing this repeatedly over time, but I'm not talking about sort of personal down to the actual individual. I'm not talking about doing, a full genomic scan or taking a biopsy from one patient and trying out multiple different combinations of chemotherapies to find the unique drug for that individual person. I'm really doing more of a macro or sort of stratified medicine when I'm talking about precision medicine here. Okay, but what we're looking for is what I think of as the Goldilocks treatment. Not too much and not too little. The right amount for a given patient at a given time. So the context that I'm working in is that we will have several different treatments or doses available. We may have this repeatedly over time. So we may have patients switching from one treatment to another, augmenting or decreasing their treatment, for example. And the context that I generally work in is using observational data. So I have to account for clinician decisions about treatments that are assigned to patients. And that's really where the causal notions come into the work that I do, is really dealing with issues like confounding. Then what I want to do is make use of the data that I have on patient characteristics. This could be demographics, it could be genetics or genomics, although I don't generally work in the very high dimensional setting, but we do have tools to deal with that. Physiological or clinical measures, medical history, even treatment history, to try to determine which treatment a patient should take at various points in the course of their illness or their treatment path. So why do I want to do this? Why do I care about these treatment effect heterogeneities? Well, I care about them if there is indeed this heterogeneity in patient response. If patients respond differently, such that one treatment that is beneficial for some is not beneficial for all, then I would like to try to find that optimal treatment for each individual, not just a treatment that is best overall. It may also be better to tailor treatment if patient responses change over time. So what's right for me now might not be right for me in a month or in 6 weeks. And that may be due to a changing course of disease. It may be due to side effects or changing patient preferences. There are a variety of reasons why what works now may not work later. Okay. It may also be the case that learning about how I respond to treatment now is actually diagnostic, and it tells me how I should be treating another patient in the future. So learning about, for example, if a class of drugs is effective but has intolerable side effects, one wouldn't want to just add on or augment the dose of that drug. It would indicate a switch to an entirely different class. Okay. But the big idea is really, again, that Goldilocks principle. Overtreating is bad. It can lead to side effects, it can lead to poor compliance or treatment fatigue, and it leads to higher costs. Even in Canada, we largely pay for our drugs, even if we don't pay for our medical treatment. But undertreating will lead to poorer patient outcomes. We have, subtherapeutic outcomes that we don't want to see. So we want to find exactly the right treatment and not provide more of it than we need. So if I think about this rather than heuristically, but more mathematically, what am I looking for? Well, I want to adapt treatment when I have treatment covariate interactions. So if I look at these 3 plots here, and you think back to your very first regression course, maybe your second regression course, when you start regressing with 2 variables, imagine along my y-axis, I have some good outcome, quality of life, survival time, something that's positive, something that I want. And along the x-axis, I have some covariate, BMI, blood pressure, you name it, some covariate of interest. And what I'm plotting in each of these 4 boxes is my expected response as my covariate changes for 2 different levels of treatment, the solid line and the dashed line. So I can see in this far left-hand picture that the solid dash treatment on average is leading to better outcomes. And it does this across the range of my covariate. So uniformly, that is the better treatment to recommend. If this is the only covariate that affects treatment, well, there is no treatment covariate interaction at all, there is no reason to ever assign this dashed treatment. If I move over to my middle plot, I now see I do have a treatment covariate interaction, but over the range of my covariate where I actually have people, it doesn't matter. Sure, there's less benefit down here, but uniformly the solid line treatment is preferable. It's only when we have this crossing of lines over the range of my covariate, where I actually observe people, that it is useful to use this covariate to assign treatment. And what we do is look for that crossing of the lines, because here, out at the far right-hand side of my figure, it's preferable to treat with the solid line. And down here at the lower end of my covariate, it's preferable to treat with the alternative, the dashed line treatment. So that's what we're looking for. We're looking for covariates where there is an interaction between the treatment and that variable within the range of my covariates where it actually makes a difference to how I assign treatment. So variables of this type that interact with treatment in such a way that would change my recommendations are known as prescriptive or tailoring variables. And what I'm trying to do in my work is identify covariates like this and use them to determine what treatment to allocate to a given patient profile. Okay. Now, the treatment regimes or rules that we get from this go by a bunch of different names. In the biostatistics literature, they're often known as adaptive treatment strategies or dynamic treatment regimes. But these are used in all sorts of different areas as well. So in the sort of social sciences, they're often referred to as adaptive interventions when targeting behavioral therapies or education. Computer scientists do this as well. They tend to refer to these as policies. So there's been a lot of interest in estimating and inference for these types of treatment strategies, both in the statistics and the computer sciences literature over the last 2 decades or so. Probably the oldest and most common strategy is what's known as Q-learning, which is what I'll focus on today. But there have been a host of other developments, some of which are regression-based, like G-estimation or dynamic weighted OLS, and some of which are more classification-based. So they're weighted, what are known as value search estimators, but essentially they are weighted classifiers, outcome-weighted learning, residual-weighted learning, and so on. So some of the challenges that we have to address in this area is that studies frequently collect a lot of variables, especially when we're looking at observational data sets where there's a whole host of variables that have been collected. Many of them are useful for confounding control. A smaller, often much smaller subset are useful for tailoring treatment, but we're not really sure which those variables are. We would like to simplify our adaptive treatment strategies, have rules that depend on fewer variables if we can, both to improve statistical efficiency, but also to yield more practical treatment rules. Really complex treatment rules are not, in general, very feasible to implement in clinic. It is true that most clinicians now have some sort of smart device with them, either in their office or in their pocket. But having to have a separate app or calculator for every possible diagnostic or treatment strategy is just not really feasible or practical. So having simpler rules is certainly preferable for clinical implementation. And finally, we have to deal with confounding. We have to be very careful in our adjustment and modeling to ensure that we are not actually recommending a treatment because it is always recommended to healthier patients, rather than because it is leading to healthier patients. So we wanted to develop a flexible tool for estimating these adaptive treatment strategies in the context of censored outcomes while appropriately quantifying uncertainty. So I'll start with a basic introduction to Q-learning, a very simple overview without censoring. And then I'll try to build up from that, from the single stage to the multi-stage setting, and then introducing the censoring. So in a single stage setting, we have some pre-treatment characteristics X, a treatment received, and an outcome Y. Okay? And so I want to know, how do I figure out what treatment A will maximize the outcome, allowing that treatment A to depend on covariates X. Now, if I only had a single treatment decision, I don't have a sequence of decisions to make, I could think about doing something as simple as regression. So let's start with a simple linear regression model. I've got my outcome Y. Again, I'm going to assume bigger is better. I have some covariates X, for example, a symptom score, or I've got a treatment A. The simplest model I could think of that might allow for some treatment tailoring would be the model that adjusts for both a main effect of treatment and an interaction between treatment and my covariate S of X, or SX, excuse me, symptoms. So what I have here in blue is what's often called the treatment-free part of the model. Okay? It's the part of the model that includes the intercept, any main effect of my covariates, but doesn't include the treatment or any treatment covariate interactions. I don't really care about this part. This is actually a nuisance part of the model. What I really care about is the contrast, how treatment affects my outcome and how it is modified by other covariates. And the reason that I care about this is the part that if I was in charge of allocating treatment, this is how I can modify the outcome, right? I can't modify my patient's covariates directly. They come with the patient. But what I can do is modify their treatment and try to therefore improve their outcome. So if I had just a binary treatment, this contrast function would imply a simple linear decision rule. It would say, take whatever is inside here. Whenever that's positive, I want to allocate treatment level A equals 1 if I've got 0, 1 coded treatment. Whenever it's negative, I want to wipe that out because that's leading to a smaller expected outcome. So I would assign treatment A equals 0. So that's how, if I specify a simple linear regression model, I can get an implied decision rule that simply takes the covariates and the estimated parameters inside this contrast function, checks if they're greater than 0, and assigns treatment accordingly. This is like that little plot that we looked at. We're just looking at the sign difference between my solid line and my dashed line and using that to assign treatment. All right, so that's the simplest way of generating an individualized treatment rule in a one-stage setting. But often we have chronic illnesses or we have illnesses that require more than one treatment. We have multi-stage settings. That's where things get messier. So I'm going to sort of try to explain this in a 3-stage setting, but my ultimate case study is actually just a 2-stage setting. So with this multi-stage setting, things are more complex. I want to be able to learn about the optimal treatment at each stage, realizing that my choice of treatment at one stage may impact the set of possible treatments at future stages, right? I have to be very, very careful. If I allocate a particular treatment, even if it leads to good short-term outcomes, it may close the door for subsequent treatment options that would lead to an optimal longer-term or delayed outcome Y. Okay, so the way that we tend to do this is using a dynamic programming or backwards induction approach. What I'm going to do to simplify things is move from this DAG presentation to a simplified picture. Okay, this is not a DAG that I'm showing you here. So please, I know this is a causal talk and everyone is used to DAGs. This is not a DAG. This is just a simplification of what I've done, but I'm still assuming all of those causal dependencies from the previous slide. The reason I want to simplify it in this way or take out some of the arrows is so that I can focus on the stage by stage comparisons. Because even though I have this complex structure where I'm trying to learn about how to adapt treatment at each stage, possibly giving all of these previous covariates, the way I'm going to do it is to break it down into several stages, but I'm going to start at the end. So we take a backwards induction approach and try to learn about the optimal stage 3 and roll our way backwards in time. So what I can do then is I can collapse everything that is relevant prior to my final treatment stage into what I call H3. It's my history prior to that third treatment. It may be very high dimensional. Often it isn't. We often don't actually need all of that history, right? Sometimes we'll have just 1 or 2 key variables that are useful for tailoring. But for now, I will just think of this as encompassing all of the history of that patient up until this point. Well, if I rewrite all of that history as H3, this looks like something we've seen before. This is a one-stage problem. I can do the same trick that I did before to learn about optimal treatment at the third stage. Problem solved, almost. Problem solved for one stage. Once I've learned my optimal stage 3, what I want to do is move back to the second stage. Okay? And what I want to do at the second stage is, again, a one-stage type of analysis where I learn about what is optimal treatment at the second stage, given everything that happened before then. But I've got to figure out how to treat my outcome. Right? What is this Y2 that I've written here? That's not the final observed outcome that I have. This is something that we often call a pseudo outcome. Because one thing we know, if we think about randomized trial settings or really anything in a causal setting, is if I have a treatment of interest, I don't want to control for or adjust for anything that happens after that treatment, right? I worry about blocking the effect of that treatment. So what I want to do is learn about optimal stage 2 treatment without explicitly controlling for the stage 3 treatment. And at the same time, I want to ensure that everyone's on an equal footing. So how do I do that? Well, I create this thing called the pseudo outcome. And what I do is I take the observed outcome and I adjust it to be equivalent to a counterfactual in which everyone received their observed treatment at stages 1 and 2, but they received what we believe to be the optimal stage 3 treatment. If everyone is treated according to the same rule in stage 3, then I don't need to adjust for it. Everyone is on an equal footing. So that's what we do to create this pseudo outcome. Okay. Typically, we compute this simply by predicting the outcome under the estimated optimal treatment. So when I do my stage 3 analysis, I get an estimate. For example, if I did a linear regression, I would get my linear decision rule. I can use that to predict the optimal treatment for each individual. And using my linear regression, I can then say, well, what would the outcome have been had each person been treated optimally? So I can essentially impute this stage 2 outcome using the model to learn about my stage 3 treatment. That's what's done in Q-learning. We work our way backwards doing single stage analyses, and at each stage adjusting the outcome to essentially give back that extra bit of outcome or improve the observed outcome by what we think an individual should have had they been treated optimally. So like a lot of causal methods, Q-learning does rely on standard identifiability and estimation assumptions. We rely on SUTFA, so there's no spillover. We have independence. We must assume positivity. I assume that there is no unmeasured confounding or any other problems in my data, no measurement error, no selective information, or indeed selection bias. And very importantly, we also have to assume correct model specification. That's obviously a concern, particularly if we were fitting simple linear models. Ying, was there a question?
Yes, there is a question. I think this is probably a clarification question. So the person asks, could unobserved confounding influence this multiple stages design and how to control for it?
Oh, absolutely. Unmeasured confounding would be a huge problem. And by and large, we assume it away. Almost all of the methods, not quite, but almost all of the methods in dynamic treatment regimes rely on the no unmeasured confounding assumption. There are some sensitivity analyses that can be done to try to estimate the impact of unmeasured confounding, but there are very few methods that are really adequate to take, for example, an instrumental variables approach to this. We generally do assume that we don't have any unmeasured confounding. Thank you.
Thank you.
All right, so we've gone from a simple linear regression to several linear regressions done recursively with adjustments to our outcome. How do we now do? Oh, yes.
Sorry for interrupting, but another clarification question pops up.
Yes.
Philip David asks, are you assuming the utility is linear in the response?
So that's a great question, Phil. Sometimes. The standard Q-learning approach does indeed assume it takes the outcome to be a utility. So for example, the quality of life itself could be treated as a utility. we could have again, a univariate utility that measures things like qualis per certain amount. And in fact, Peter has done some work looking at a utility that measures, I'm trying to remember it now. It assigns values to both the probability of remission and the severity or the toxicity, severity of side effects, something like that. So there was this utility surface that was elicited by...
Erica, you want me to clarify that?
Sure, go for it.
So what we've been doing for quite a long time is to look at multiple outcomes. In the simplest case, say you've got binary toxicity and binary response. So there are 4 possibilities. So you have a 2x2 table and you elicit utilities by first assigning a utility of 100 to response without toxicity, 0 to toxicity without response. And then you elicit the 2 intermediate values. And then you use your, in the Bayesian world, posterior mean utility as your decision criterion. So it's a way of combining outcomes to do dimension reductions so that you can do decision making, and it can be applied anywhere.
Thanks, Peter. So yes, different utilities can be used. Assumptions about how the treatments or indeed the covariates affect them really are encapsulated in the models that we specify for the Q-learning. So what I've shown up till now is just a simple linear model, but given the need for that model to be correctly specified to actually get correct or good performing treatment rules, it's a pretty strong assumption. And that was part of the motivation for trying to find something that is more flexible. So I will move quickly to the censored outcome setting. This doesn't pose too many additional challenges, but it does pose some. So forgive me for having to introduce a little bit more notation. Again, I'm going to treat my or denote my treatment options by A, subsetted or subscripted by K for each stage. I will have pretreatment covariates X, again measured at each stage. And within each stage, within each time point, I'll have time measured and denoted by TK, but I should note that patients may experience the event of interest at any point, or they may be censored at any point. So not all patients will enter all stages the way I assumed they did in the simple continuous outcome setting. Okay, so my total observation time, well, everyone enters stage 1 to be eligible for the analysis, but subsequent to stage 1 will depend on whether they actually entered subsequent stages, which they may or may not do, depending on whether or not they were censored or whether they experienced the event of interest prior to entering a given treatment stage. I have an event indicator delta, so the totality of my data is just these pairs of pretreatment covariates, the treatment and the time spent in that interval, and then subsequent triplets like this for each stage of treatment. So in a two interval setting, for example, I would have baseline covariates, stage 1 treatment, time spent in interval 1, an indicator for whether they move on to the second stage. If they do, we have pretreatment covariates, second stage treatment, and the time spent in stage 2, and an indicator for whether or not they experience the event of interest. But of course, this triplet here will be unobserved if they don't make it into the second stage. Now, Q-learning is probably the most popular approach for censored data, largely because of the ease of use. It can be implemented with any variety of models. Again, Cox models are relatively commonly used, but we do need some estimate of the baseline hazard to be able to create a pseudo outcome. There have also been accelerated failure time model implementations, Weibull models, so parametric models. I've done some work with Pareto models even. So trying to estimate these adaptive treatment strategies using fairly typical methods for censored event time data. Because Q-learning is just this backward sequence of regressions, it is relatively easy to use. Okay. But again, just like in the uncensored outcome setting, my unbiased estimation of those parameters and thus subsequent treatment rules depends critically on whether I can correctly specify my outcome model. Furthermore, in the censored setting, we typically require that the censoring and event times are independent given covariates. So censoring doesn't have to be completely independent, but it does need to be independent of my event time, given the covariates that I have measured. So the Q-learning that we saw previously does extend very naturally to censored data. Basically, we are again recursively applying this idea of regression, predicting the outcome, which in this case is a time to event under different treatments to compute our pseudo outcome. But we do have a little bit of nuance in dealing with individuals who experience events in early stages. So for example, someone who experiences the event in the first stage simply will not contribute at all to estimation in the second stage. Even if they were treated suboptimally, we don't adjust or allow them to contribute to any subsequent stage estimation. Okay. We still have some challenges to think about in the censored outcome setting. So Q-learning is typically designed to model means. Means are generally seen as less relevant when working with censored outcome. We're often interested in median survival time, for example, because survivals tend not to be, symmetrically distributed. The other thing to think about with Q-learning in particular, if we're trying to do these predictions, so trying to create these imputations for the pseudo outcomes, specifying a given parametric model at one stage may lead to a setting where the pseudo outcome at the next stage doesn't follow any known parametric distribution. So for example, I can't have a Pareto distribution of outcome times at both the first and the second interval. They're not compatible if we try to add them together. Oops. All right, so I'm going to talk now about a flexible Bayesian approach that was proposed by Tom Murray, now at the University of Minnesota. He proposed something called Bayesian machine learning as a flexible sequential way of implementing Q-learning in an uncensored outcome setting using a series of Bayesian regression models. So essentially, it's the same idea as Q-learning, but it's done in a Bayesian framework. So at the regression at the very last stage, draw a posterior sample of the parameters in that outcome regression model, however we want to specify it. We can then set our optimal action to those that maximize the predicted outcome given the observed data. We can then compute our pseudo outcome using draws from this posterior predictive distribution. Then for each of these M draws from the posterior predictive, we want to again compute a regression at the first stage. So it's computationally pretty intensive, but it has an extraordinary advantage, which is this natural and automatic seamless propagation of the uncertainty through these multiple stages of estimation, which does not come easily or naturally in most frequentist implementations of backwards induction. So what we did was a very simple extension of Tom's Bayesian machine learning to accommodate censoring, but we wanted to do this using Bayesian additive trees to fit these models in this time to event setting. So we used BART, which is an ensemble method that fits Bayesian non-parametric regression models in the context of accelerated failure time models. So essentially we were assuming log normal errors on our log survival or on our survival time, excuse me. So the model that we're fitting looks something like this. We have a centering of our data, which is typically the average of the log survival time, a sum of several regression trees with a BART prior placed on these, and then again, this assumption of normality on our log survival time. Okay. Where again, we imposed an inverse chi-squared prior on our variance component for the log error terms. Is there any special reason for choosing BART? The main reason we chose BART was really its flexibility. I suppose we could have put, I don't know, some sort of equivalent of splines or something like that, but really we just like the flexibility of BART, although its flexibility comes with other challenges in terms of interpretation, which I'll get to when I get to the case studies.
Erica, we also have
Yes.
Brent here now in the Q&A, so we can leave some questions in for Brent or towards the end.
Okay.
So you don't have to stop all the time.
Great, thank you. All right, so I will quickly then just give you the sort of nuances of what we did. I mean, again, we run this regression. Our regression was an AFT BART model on the stage 2 data. I'd say where the more interesting nuance came was creating the pseudo outcome for this stage 2 event time. And what we did, which is not the only possible choice, and we did explore other choices, but ultimately what we decided on is if an individual's observed treatment matched what we estimated to be the optimal treatment and they experienced the outcome of interest, we didn't touch their time. Okay? Their observed survival time or their observed event time was taken to be the pseudo event time. For those individuals who were observed to be treated according to what we estimate to be the optimal rule, but who were censored, we took a draw or a prediction of their event time from our BART model, but we truncated it so that if the prediction was less than their observed time, we wouldn't actually predict a shorter survival time. We were essentially imputing a survival time or an event time for them, not allowing it to be any less than their observed follow-up time. And finally, for those individuals who were not optimally treated, we simply took a draw from the AFT BART model. So we get a posterior predictive draw and use this to impute this pseudo outcome at stage 2 for each individual. We add that pseudo outcome to the observed time at stage 1, and then we run a separate AFT BART model, again, for each of the M draws from our posterior predictive at stage 2. So again, it's computationally demanding, but it brings us lots of interesting things, not only as I said, this incredible automation of the uncertainty quantification, but we'll see it also allows us to do lots of interesting transformations if there are different targets that we ultimately want to use as our utility or our optimizer for the treatment rule. All right, I'm not going to give you detailed simulations, but broadly we looked at a sample size of 800, which was far less than what we have in our real data set. But we thought it was sort of a reasonable sample size in terms of optimizing computational efficiency and still not being too optimistic in terms of sample sizes one might have for an analysis of this nature. We had stage-wise covariates that were binary, uniform, and normal. So we were trying to look at a variety of different types of covariates. But stage-wise treatment was only allowed to depend on one variable, one that happened to follow a uniform distribution. So we didn't have a lot of complex confounding. 40% of our sample experienced the event in stage 1, and censoring was random, occurring in 20 to 30% of the sample, which was to match our case study. So we proposed using this AFT BART and compared it to Q-learning with log linear models. So really a simple linear implementation of Q-learning. Okay, and then we used a separate test set to evaluate the performance. We had 2 scenarios. I know this is a great big mess of equations, but the big picture is scenario 1, everything was linear, so we would expect the standard Q-learning to do well. Scenario 2, we had nonlinear covariate effects, sines, causes, squareds, and so on. So there we would not expect to see such good performance from the standard Q-learning. And indeed, that's exactly what we find. So in both of these 2 panels, so the first panel you see is stage 2. The second panel is stage 1. I realize that feels like a counterintuitive ordering, but it's the ordering in which we perform the analyses. The furthest to the right that you'll see is the oracle, fitting the exactly correct model. Next to that is the performance of our BART, and what we're plotting in these bar charts is just a mean squared error. Next to that, we have 3 different implementations of the Q-learning. And what you see is 1 FRT, 2 FRT. So whether it's false or true, correct or incorrectly specified in the 2 stages of the Q-learning. And so what we see sort of here in this 3rd bar or here in the 2nd bar is when I get correct specification in Q-learning, things are beautiful, right? I'm fitting the oracle model, everything is great. But if I get it wrong, there is a great big penalty. And it's not just a penalty in terms of estimating my parameters, because you might say, well, if you've got biased parameters, but you get the treatment right, who cares? It turns out that we are getting the parameters wrong and it is impacting our decision making. So what these lines that I'm showing you here are plotting is what we call the proportion of optimal treatment. how often are each of these different strategies recommending the treatment known to be optimal in that independent sample of 400, okay, that test sample. And so what we see again is if I get everything right with Q-learning, I do really well. I recommend the right treatment almost all the time, okay? But if I get it wrong, I do really badly, whereas BART on the whole is doing well without correct specification. Again, this is just in my linear setting. When I moved to the log linear setting, we had two different incorrect versions of Q-learning, one that had main effects only, one that included some interactions. The interactions do a better job of capturing some of these nonlinearities, but we're still seeing significant underperformance relative to BART. BART's doing, very well in one interval, not as well in the other, but that flexibility is buying us a lot in terms of reduced MSE and in terms of better performance or better prediction of the optimal treatment. We looked at some additional scenarios, so misspecifying the distribution, the errors on those log event times. Things performed well. We assumed covariate dependent censoring rather than purely random censoring. Again, our AFT BML performed really well, but this was to be expected given that we don't require completely independent censoring, just independent given covariates. All right, so I will quickly try to wrap up so that we have some additional time for the questions. I don't want to keep too many people, whether I was going to say over lunch, but I know it's breakfast for some and probably afternoon coffee for others. The analysis that really motivated this work was looking at allogeneic, I'm not going to get this wrong, stem cell transplantation. We'll skip over the word I have trouble with. So essentially transplanting stem cells that give rise to the red and white blood cells and platelets. It's a common treatment for several different blood, bone marrow, and lymph node diseases and cancers in particular. The graft can come from lots of different places, bone marrow, circulating blood, or umbilical cord blood. And there are different degrees of matching of the donor and the recipient. These HLAs are how we distinguish the matching. And it's what's used by the body to sort of identify cells as our own or others. If there are significant differences in these HLAs or other minor antigens, the recipient, the person getting the transplant, can have what's known as graft versus host disease, where the graft, what's been transplanted into them, is attacking the recipient's normal tissues because it is viewing it as other, some foreign cells. So to lessen the risk of this graft versus host disease, patients are given immunosuppressants prior to getting the transplant or the graft infusion. These immunosuppressants are tapered over various, windows of time, but there are different types of immunosuppressants. And so there are many, many different types, probably on the order, there must have been over 20 in the registry we were looking at. And so we classify them very broadly into what we call standard therapies and the more aggressive NHTLs, or non-specific, highly T lymphodepleting treatments. These more aggressive NHTL treatments are believed to reduce the risk of graft versus host disease and improve GVHD outcomes if it is developed, but they also carry increased risk of opportunistic infections because they are sort of broader spectrum, more aggressive immunodepressants, or suppressants. So, and they can also, in some cases, increase the risk of cancer relapse. So there's good reason to think that they may be useful for some patients, but they're aggressive enough that they certainly wouldn't be given to all patients. All right, so what we want to do is really get a causal understanding of these treatment effects so that we can make tailored recommendations to patients. We use data from an international registry of blood and bone marrow transplants. The registry gave us data on just over 11,000 patients who were transplanted between 1995 and 2007. We used slightly fewer of those in this particular analysis, 9,500. But confounding was a major challenge in this study. The patients given the more aggressive treatment had more advanced disease, meaning cancer, the reason they were getting the treatment, at the time of the transplant, and they were more likely to have had a mismatched donor, so more likely to develop graft versus host disease because of this HLA mismatch. All right, so what I am showing you now is simply the results on the left-hand side here of the AFT BART versus the right-hand side here. This is a standard Q-learning implementation. As it turns out, we don't get such different results, suggesting that maybe the models are not too far off linear. What we're seeing here is the median disease-free survival time as our outcome. Positive values favor the more aggressive therapy, the NHTL. So you can see, for example, here, this is my 0 line. There's a significant, I always tell my students, don't use significant in statistics. There is a meaningful number, a considerable number of individuals over the 0 line, suggesting there are a considerable number of individuals who would benefit from receiving the more aggressive treatment prior to their transplantation, so as a prophylactic. In stage 2, we can see there's almost nobody above 0. So almost nobody would benefit from the more aggressive treatments if they develop graft versus host disease that doesn't respond to initial therapies. So what we're learning from this is that really there's very little advantage to tailoring treatment at the second stage, but there could be significant advantage, considerable advantage, not significant, to tailoring at the first stage. Now, one of the things that was asked earlier was, why BART? And that's a great question. BART is flexible. We like the flexibility. We like the less parametric side of BART because we have this assumption of correct model specification, right? We need correct model specification to get this right. And that means we need correct model specification to deal with confounding, but it leads to horrible treatment rules. They're totally uninterpretable. We can't write them down. So what did we do? Well, we kind of did a little bit of a hack. We got the predicted differences in our log disease-free survival time, and we fit a simple tree to those. What does this give us? It gives us an approximation to the recommended treatment rule that's coming out of the BART based on this simple tree. We get to see whether individuals are receiving a transplant or a graft from a related or an unrelated donor, and where that graft is coming from. Those are the main predictors of whether or not someone should receive the NHTL versus the standard treatment. Now, this is not going to exactly replicate the rule that comes out of feeding a patient's covariates into our BART and getting a posterior predictive outcome for each individual, but it gives a reasonable approximation and hopefully could do if we needed to have something sort of on the fly for physicians, or if nothing else, if we could build them a predictor in their little smartphones or whatever else they're using in clinic. Physicians still generally like to see what the rule is doing, give them some sense of whether this has any face validity and whether it agrees with what they might expect. And certainly this rule does seem to agree with what they might expect, in that the more aggressive treatment is being targeted at those with unrelated donors. So donors who are less likely to have a good HLA match.
Hi, Erica, I can see you're almost done, but if you can wrap up, please, within a minute and a little bit.
1 minute and I'm out. Thank you. So I just wanted to show you one other benefit to working within the BART framework. We get this posterior predictive distribution for our outcomes. We looked at disease-free survival time, but we can make any transformations of that and learn about optimal rules. So for example, if I wanted to focus just on 2-year survival, I could do that and target the probability of 2-year survival. Doing that again, we see somewhat different rules. And interestingly, we see a bit of this almost stepped pattern from the BART model, probably a result. It's a bit of a funny one. We've puzzled over this one. I mean, the multiple trees, we would expect a bit more smoothness, but actually we're not getting such different recommendations in targeting 2-year versus median survival time. All right, so but just to wrap up, I will say I do think that these adaptive treatment strategies have enormous potential to improve clinical practice. Doctors are personalizing our medicine all the time. What we would like to do is give them tools to use large data sources to make sure this is being done in an evidence-based way. However, we need tons of data to do so. We're trying to learn about treatment covariate interactions or treatment effect heterogeneity, and it's just really hard to do this. It's always underpowered. So we need lots of information, lots of big sample sizes, and ideally we want a generalizable population. So that tends to push us towards observational data, but gives us all of the problems that we face in observational data that call on us to be causal researchers. Using flexible models is undoubtedly the way to go, or indeed using something that might rely on leveraging double robustness if we think that we can model treatment allocation decisions better than the outcome itself. Finally, I'd like to say that this Bayesian approach does give us nice uncertainty measures, and although I haven't shown it here in other work that we've done, we've seen that we can actually attach probabilities to the recommendations, which could be useful for physicians as well. You know, I recommend this treatment with probability 0.9. The doctor you would hope would listen to, I recommend it with probability 0.6. They've got a little more discretion. That said, I mean, we've done a lot. We've come a long ways. I've been working in this field for over 20 years. There's still a long way to go, okay? Even when using these highly non-parametric rules that help us get away from issues of, or maybe some of our concerns, lessen our concerns about model misspecification, we then are left with complex rules that are hard to interpret. So this fit using a simple tree helps, but is it good enough? It's hard to say whether it would actually be satisfactory in practice. There are other issues I probably won't, well, we can get into them if there are questions, but just to say we've done a lot, but there is still a ton to be done, which makes this a fun and interesting place to be playing around statistically. So thank you very much.
All right, thank you, Erica. So there are a few questions in the Q&A that are still not answered, but for the sake of time, we can move to discussion. And if we have any minutes left in the end, we can take those questions. So we have you, Cheng, and Peter Thall as our discussants. And I think, Peter, you starting us off?
Okay, I'll do a share screen, see if it works. Can you see my screen?
Yes.
Okay, let me just see if I can quickly change pages here. There we go. So all roads lead to Rome, and I'm congratulating Erica on conversion to Bayesian thinking, better late than never. But actually, I think she's done quite a brave and bold job of attacking a really hard and very, very important problem in graft versus host disease prophylaxis in allogeneic transplant. My first question is, let me just run through the questions and then Erica can talk about them. I was unclear on what censoring means in this setting, and in particular, whether it might be associated with some outcomes. So the question is, can you give some examples of independent or dependent censoring in the context of the graft versus host disease prophylaxis? My second question is that an allogeneic transplant patient may be forced to delay a treatment stage because they experience some severe adverse event. This is a very aggressive treatment, and it's caused by some covariate, combination of the covariates and the treatment effects. As an example, graft failure, which is graft rejection in stage 1, can only be treated by a second transplant, or they're going to die. So the stage 2 action would really be a choice of, what preparative regimen you use for that second transplant and the GVHD prophylaxis. And of course, you'd have to adapt the decisions. I guess in your data, it turned out whether the donor was a match or a mismatch mattered a lot. But again, this could be delayed because the patient has got organ failure or sepsis. So the question, this is complicated, yes, but it's realistic. How do you deal with all of this? Third and fourth questions. The decision to give non-specific, highly T lymphodepleting GVHD prophylaxis or not was related to the disease severity and the degree of mismatch, or whether or not there was a mismatch, I guess. So how do you deal with this selection bias? The huge question. And I'm curious to know, just by the way, whether they used cellular therapy as these agents. So that's my share. I'll do a stop share now.
Thank you, Peter. I'm, what can I say, lucky that Peter gave me a bit of a heads up, so that will hopefully allow me to answer these questions a little more sensibly. So Peter, the first question you asked about sort of what is censoring and what does it mean? I mean, we only considered first transplants. So we did censor individuals if they were lost to follow-up. Who knows if that's independent or not? Genuinely, we don't know. These registries are pretty good and pretty well connected with vital statistics. So I don't think we would be missing any deaths, but I could be wrong. They are also censored at a time of second transplant. So that would almost surely be not independent. If they die awaiting a second transplant, they would count as an event because our outcome is death, disease persistence, or relapse. And disease persistence or relapse here is meaning the initial cancer that caused them to get the graft. The other reasons for censoring were receipt of an NHTL salvage treatment for chronic GVHD prior to or without getting any treatment for the acute GVHD. So that was sort of a decision we made on that the second stage was really a salvage treatment after having received treatment for acute GVHD. That was a relatively small proportion of patients, and we just considered them to be unusual and hard to model. So those latter two sources, so the second transplant or receipt of an NHTL salvage without having had any treatment for acute GVHD, I would say that's likely correlated with the outcome. Although it's not clear to me if it's correlated given things like baseline severity, HLA mismatch, and so on. So I don't have a good answer for you. I think it's possible our assumptions are being violated, that we may be missing some covariates that would be required to give us that conditional independence. Again, anywhere we would have a latent health status that's not captured by our covariates. Other comorbidities that, for example, that weren't captured by our Karnofsky performance score, I would be worried about the censoring not being independent, conditional on the covariates we've measured. How could we deal with this? Possibly in a competing risk setting or looking at a multiple outcomes DTR. So, I mean, another way to deal with this would be to have a more useless outcome, by which I mean a composite outcome that has more elements in the composite. But I think that gets more difficult in that it's hard to know what you are actually truly targeting then as your utility. With the competing risks, I also think it's a bit of a tricky one. I actually have a student working on this now, but understanding and weighing the negative utilities of these different outcomes is also difficult. That's something we're grappling with. Your second question was, let me see now, whether we could distinguish, yes, from the data sources, if someone is going on to a second transplant. So as far as I know, we can't really distinguish. If they go on to get a second transplant, they had NHTL prior to that. I don't know that we could distinguish whether that NHTL is conditioning for the second transplant or treatment of the GVHD for the first transplant. So I don't think that we could actually distinguish those. We have treated those as NHTL treatment for graft versus host disease of the first transplant and then censored them upon receipt of the second transplant. And then your third question was asking about selection bias. I think I might push back and say I'm not sure that it really is selection bias. We actually definitely do have confounding. Maybe I'll share again just momentarily. This is sort of digging from another talk, so change for different color scheme here. At the first interval, I mean, we do see that the NHTL, the individuals getting the NHTL by and large are not surviving as long. They're having faster outcomes. At the second stage, it's even more dramatic. But this dramatic difference is really being driven by the fact that these are much sicker patients with poorer matches. So I don't know that it's a selection bias issue, but rather it's a confounding issue, which we hope we are addressing through direct adjustment via our flexible BART models.
I guess the reason I ask it is it's very reminiscent of the stuff in the Hernan, Robbins, and Brumbach paper in 2000, with AZT. It's the same sort of thing.
Absolutely, yes. The sicker patients are getting the stronger treatments, and the only way we're really tackling it in this particular case is through our covariate adjustment. And then the final thing I will share a screen for, because I'm gonna have to rely on you to make sense of this. I dug out lists of the different treatments, but honestly, I can't speak to what these mean, so I'm not sure, but I hope that this answers your final question.
Thank you.
I will say that this project did start with a bone transplant specialist. A lot of the work on this particular registry grew out of a transplant specialist who did her master's in epi at McGill, and we worked on these problems together. So I trust her call in, distinguishing these drugs, but I can't vouch for it personally, other than to say I trust Elizabeth.
Okay, so we're already a minute after time, but I want to also give you time to ask some of the questions that she might have. And if we can, maybe we might have to wrap up a few minutes late, but I also want you to have the chance to ask her questions.
Oh, we can, right? Okay, great. I have a similar question that Peter just asked about the difference between those patients who actually got anti-HL and those actually got standard ones. You mentioned that you try to adjust for that in the a covariate adjustment, but on your last slides of your presentation, you have some weighting method. I wonder whether you are thinking of how might adjust for this one.
So, I mean, there's different ways of sort of tackling this within a more standard regression framework, and also within the frequentist framework. So I will admit that is my training, and frequentist land is my comfort zone. I am stretching beyond my comfort to do things in a Bayesian setting, I will admit. But we've looked at essentially weighted series of regressions to implement Q-learning or Q-learning-like methods, where we do weighting. It can be done using overlap weights or using inverse probability of treatment weights, also incorporating weighting for censoring as a way of addressing confounding and providing some double robustness. At the moment, the AFT BART package doesn't handle weights, and so we weren't able to incorporate weighting into the BART fitting. But I will again quickly share some work. This is based on similar work where we were fitting somewhat different models. In this case, the red is showing where NHTLs are preferred. And again, the results are not so different. We see quite a number of individuals who might benefit from the NHTLs in the first stage. Here we found a few who might benefit at the second stage, but again, that benefit is really minimal. So, I mean, it's a very different approach to fitting, but we're not seeing dramatically different results. So I think ultimately it'd be great if we could incorporate some more of that robustness via the, essentially propensity score modeling in the BART, but we haven't made it there yet.
Thank you. Do I have time to ask another question, or should we address a question that's in the Q&A?
Please feel free to ask here.
Okay. I'm really interested in the composite endpoint. So right now in the data analysis, you kind of lump the relapse and death together. So you did mention that using some competing risk model. So I wonder whether there's any interest to develop methods for relapse time or death separately. So then you can, instead of just lump them together as a composite endpoint.
So I would, yes, I have tons of interest in this, but I haven't made any progress. Well, I shouldn't say I haven't made any, but it is very much a work in progress. And so I don't have anything I want to share just yet, but it is definitely an area of very active interest for me, because I think it's very feasible to come up with a method. Whether or not it is feasible to come up with a method that is really meaningful without maybe doing something like what Peter mentioned before of sort of eliciting utilities on how bad each of these outcomes are. I mean, relapse is lousy, death is arguably lousier, but maybe it depends how bad the treatments are for that period of relapse. You know, trying to weigh these different outcomes so that not only are we looking at sort of the time of wellness to that outcome, but how bad that outcome really is something that I think requires a lot more thought and also a lot more input from clinicians. It's definitely not something I could come up with sort of independently. So we're still puzzling out the statistical side, but there's a lot more crosstalk that needs to happen.
Right.
Great. Probably we are at the point that we can wrap up. So thank you, Erica, for the great talk, and thank you, Yu and Peter, for the great discussion. We still have some questions in the Q&A, but we will forward it to Erica afterwards. And yeah, so if you want to discuss with Erica, maybe you can directly reach out to her. So let me wrap up with the end slide. So next week, we'll have Matt Stanford and Aaron Sarvit from EPFL to talk about interpretational errors in causal inference and how to avoid them. So again, thank you for being here. We look forward to seeing you next week. Thank you.
Thank you very much.
Thank you for having us here.
Thank you.
Great talk, Eric.